Okay, do you hear me guys? شفتوني؟ نبدي؟ Hello?
ايوه يا دكتور.
Do you hear me?
ايوه يا دكتور.
Okay, so here we were talking about our guidelines to look after very premature babies, very small. We're talking about babies less than 27 weeks or less than 1 kilogram. And here when we say curve, we're meaning from birth till about 3 weeks of life. Okay, and you know these guidelines are approximate guidelines. So some of these guidelines can change depending on the situation. So if you have any concern, you have to contact the neonatologist. Okay, so this guidelines is just to minimize the risk of losing the baby, passing away, and also the major risk to prevent major complications such as IVF, pneumothorax, PVL, chronic lung disease, infection, and so on. Okay. So as you know, before baby is born, we have to meet with the parents, as we did today with our 24-weeker, and we handed them information to parents in 2 languages, and also we explain them the risk of death and risk of major complication in general, and in their particular babies, depending on the risk factors. And as you see with our current baby, the risk of death is almost 90% because of the possible 24-weeker and lung hypoplasia. So we have to meet in the parent. Not only that, we have to keep copy of this conversation. We sign it to a neonatologist, and we need a nurse to sign it too. And we also keep a copy with parent, keep copy with us, and also we need to keep a soft copy. And that's what we did. And Dr. Marwa was with me, and I think she can explain to you some of this process. Okay, so we've described to them in details, and it's written also, and we provide them with a communication with us, a WhatsApp or an email, and so on. So we talked about the major complication that can happen to the baby and the risk of death. Okay, both parents or one of them is not, both of them are not, should sign on the information for families with the preterm delivery. And a copy should be kept in the mother file. And also I should receive a soft copy just in case. We need to call the obstetrician, which I did. So I talked with the consultant obstetrician about the delivery and the collaboration and the management. And we need to make a checklist. So yesterday, Dr. Hanan sent me a checklist, but the nurse need to make sure that this checklist is available, and this checklist need to be always discussed between the physician and the bedside nurse, in addition to the neonatologist and the charge nurse. We need to have a standard order for babies, as we sent before, for babies less than 1.5 kilogram. This standard order regarding the incubation, the humidity, the fluid, the infection control, the IVH bundle, the assisted thermoregulation, the antibiotics, the investigation, the procedure, especially the X-ray or lung ultrasound, the UAC, the UVC, the peripheral IV, the medications, the need for sedation or not, and so on. So this is the standard order. If it's not available with you, I can send it again, but it's available. Standard, a list of order need to be written for all babies with this age. The first and the most important things is we need to do pre-1 procedures. First is we have to increase the room temperature, whether it's an OT or labor room, to 25, 27. And we don't only just call. No, we need to follow and make sure that on the wall, the temperature reading is 25 to 27. We need to call the maintenance. We did today and need to be followed 1 to 2 hours prior delivery, if possible. And we need to monitor closely the temperature. We need to bring a warmer with us. So it's an incubator or radiant warmer, Ohio or Leo baby incubator, and make sure that the incubator should be always plugged in, and it can stay working for 15 minutes only. So it needs always plugged in. The humidity needs to be turned on according to the assisted thermal environment in our guidelines. If you don't have a copy, we can provide you with a copy. The copy is on the share folder. We need to humidify the ventilator tubing and set it up. We need chemical warming mattress. So we need at least 3 towels. Remember, 3 towels warmed. So I don't go to the labor room and then I don't have towels. The towels should be inside the incubator. So please make sure that we have 3 or more towels pre-warmed. The intravenous fluid, the T10, and the medication should be warmed to a room temperature. Either keep it for 30 minutes in the room or hold it by fisting your hand to warm it up. We need to warm the blanket that we will make the nest. And if you don't know how to make the nest with the blanket, you can ask and we can help you. The temperature of the incubator that transfer the baby should be 37 degrees Celsius. So this is only pre-warming. Please keep it in mind. Very important in the outcome. And one of the KPI is the temperature at arrival. When the baby arrived in ICU, what is the temperature? We need also to do delay cord clamping. The delay cord clamping should be 30 to 2 minutes, 30 seconds to 2 minutes. Very important. And then you need to tell the obstetrician very clearly that you will do delay cord clamping. And then once it started, you need to count down 10 seconds, 15 seconds, 20 seconds, tell them. And they need to communicate with you about the status of the baby. Is the baby moving? Is the baby crying? Is there a heart rate? Is the color is okay? Because once any of these happen, then you need to stop the delay cord clamping, and you need to document that. You need to put the baby by a polyurethane plastic wrap, a plastic wrap around the baby. Once this plastic wrap is become dirty, contaminated with the blood, very fluidic, you need to replace it. You keep it wrapped until the baby arrives to an ICU. If during this process removed for any reason, you need to replace it. The baby needs to be wrapped in the plastic all the time, so somebody should monitor always. If you need to access, you have to cut slits and access for lines or for monitors or for props. You cannot remove it from the legs or from the hand. You need to put a hat. Very important to remember. A hat, the head is the most important part of the body that they will lose temperature. So please put a hat. The hat should be warmed with the blanket inside the incubator. All the baby deserves CPAP. We can start CPAP with the T-piece connected to the Ohio until we decide to intubate or not. If the baby below 27 weeks and intubated for any reason, surfactant need to be given. If the baby more than 27 weeks and intubated for any reason, the decision to give or not surfactant should be discussed. But remember, what? Any question? All the baby deserve to be giving CPAP for at least 2 minutes before we decide the CPAP is failed. However, very important to also look if the baby desaturating, if the heart rate is going down. So we need to make sure that the baby needs PPP or not. You need to connect the temperature probe under the plastic wrap and connect it to the servo control of the monitor. The first temperature should be checked rectally. Before, or if you're not able to do that, you have to connect the probe in the axilla or on the back. Remember, do not use tape on the baby. The skin on the first week are very fragile and you can break down the skin. The pulse oximetry should be connected to the right wrist. And it should be rubbed, not taped. We have to monitor the oxygen saturation for first 10 minutes. And remember, in the first 10 minutes, when we reach the 10 minutes, the target oxygen should be right. The target oxygen should be in 88 to 92. If the baby oxygen persistent more than 92, and persistent mean more than 15 minutes, you have to wean oxygen. It's not allowed that the saturation is 93 and the oxygen is 30. You keep weaning until you get room air. But if it's persistently below 88, you have to increase the oxygen temporarily, and then look why the baby need. When we say temporarily, that means need oxygen more than 30% to keep saturation more than 87 for like 30 minutes, then we have to know why the baby need more oxygen. Chest X-ray, cardiorespiratory monitor will cause skin breakdown. We will only use cardiorespiratory monitor if our oximeter is not working, or if we have no arterial line. If we have an arterial line and or we have oxygen, we don't need cardiorespiratory monitor because it can break down the skin. All babies below 27 weeks need UAC and UVC. However, it time's consuming up to 45 minutes. So all babies deserve a peripheral IV and a maximum trial of 2. So if after 2 trials not, move the baby to an ICU and we'll start UAC, UVC. But if you are able, we will start IV fluid, D10 without electrolyte. Half of it is D10, the rest is protein. So if it's 80 ml per kg, 40% D10, the rest TBN plus extra fluid, the extra fluid for medications. When we do the arterial or venous line, arterial or venous umbilical line, we have to protect the spine. So when we sterile, then we have to clean all the chemicals we use to sterile the skin by a sterile water. Do not use chlorhexidine, especially this with water, more than like 30%. The secure of the line should be by suturing, not by tape. If we need to intubate, then it's appropriate size. If the intubation for baby is not breathing, then we'll keep the baby ventilated. But if the intubation is just to give surfactant, we extubate and keep the baby back on CPAP. We always need to put hydrocolloid barrier on the cheeks to not tape it because taping it, or you can use neobar, because taping it causes skin breakdown. We need to put some medication between the hydrocolloid barrier or gel between the security of the tube and the skin. We need to set the baby ventilators according to our mechanical ventilation guidelines. Please review it. Avoid the hand ventilation as much as you can. You have to put a cover on the baby during transport, and it should be pre-warm. so towel or something, to prevent radiant heat loss if the baby is not covered by plastic bag. The ventilator should be heated and humidified during transport if possible. If not possible, replace it and switch it to humidified, heated ventilator as you reach to the NICU. Same applied if you need to move the baby from one bed to another. You need to minimize the endotracheal sectioning. And if the baby has lots of secretion, mostly, I would say mostly it's a position. And please review the guidelines of the sectioning. The baby needs to be weighed daily. But in the first few days, and to prevent IVH, we put the baby in midline position and support the baby from each side by gauze or cotton in a midline position. So we don't need to move the baby. We don't need to examine the baby many times during the day. One examination is up unless the monitor tells you something else. If we cannot weigh the baby, the best way to manage fluid by looking at the sodium. Now, when we do the sodium in the first 24 hours, it usually reflects the mother. Now, in babies 23, 24, we start at 100 ml per kg per day in the first day. In the baby is 25, 26, we might reach at 80. And then we increase in a certain increment as we agreed. The reason why it's this numbers is just to make the work organized between each of us, all of us. The first serum electrolyte is after 24 hours, otherwise it reflects the mother, unless there is serious problems such as renal failure. Should be accurate in and out. We always start with minimal enteral feeding. Minimal enteral feeding is not included in the calories of every day, not included in the fluid, and it's only 10 to 20 ml per kg per day. So for 24, 23, we start 0.5 every 4 hours or every 6 hours, and 25, 26, we might start 0.5 every 4 or every 2 hours. We start either EPM or DPM, and if we don't have, we start term formula. Term formula for minimal enteral feeding. The minimal enteral feeding is 2 to 3 days. Sometimes we go 5 days. Once we start to increase, then we switch to preterm formula if EPM or DPM is not available. We always have to add oral immune therapy. EPM is, or minimal enteral feeding, is through the feeding tube. The purpose is to prime the GI, to prevent gastric gastropathy and enteropathy. Minimal oral immune therapy is we put 2 drops of milk in the angle of the mouth on each side. So 4 drops every 2 hours. That's not related to oral immune or to the minimal enteral feeding. The purpose is to prevent infection and to minimize secretion. We need to check the first electrolyte after 1 day and then daily, unless we ask for more. We need to do blood gas. We need to do umbilical, arterial and venous if we can. And then we decide whether it's a ABG if we have arterial line or CBG, depend on the situation. If it's possible, we can use point of care devices like iStat for blood gas or sugar level and so on. It's important to do assisted thermoregulation. The incubator, if it's open, there should be a radiant warmer. Now we don't have giraffe omni bed, but we use baby Leo. This is need to be removed. Always the window need to be closed. Once you open it, radiant warmer need to be open. So it's not good to open the window and start working. You have to raise the cover of the incubator so the radiant warmer start working. Don't just open the window and keep no radiant warmer and you are cooling the baby. So prevent to maintain, in addition to the temperature, the humidity. According to the graph, please look at the table of the humidity. So we prevent heat loss and we prevent water loss. Always, if you have to open, please put the baby in a plastic wrap. If the baby temperature less than 36 degrees Celsius, please rewarm the baby. But the rewarming should be 0.3 degrees Celsius of the service temperature of the baby and 0.1 per hour of the core temperature. You should never ever allow the temperature to rise more than 0.5 degrees per hour. Very important to monitor hypotension when the baby is cold and you are the blood pressure when you are rewarming. If we don't have arterial line, the blood pressure should be set every 15 to 30 minutes and need to be recorded, and a trend need to be ready for use second day. The baby should not be bathed within the next 72 hours. There should be no wait to. As you know, our thermoregulation, the temperature should not be below 20, the humidity should not be below 70 in the first week, should not be below 60 in the second week, and not below 50 in the third week. When the baby is 32 weeks, the humidity need to be stopped. The incubator need to be changed every 14 days. And the reservoir of the humidity need to be changed every 7 days, or according to the guidelines of the manufacturer. Please remember to change all the fluid. Everything need to be changed. Once you change it, need to be in a room temperature. Turn the light off. Please don't keep the light off. You can use indirect light if you want to look at the baby. Always shield the baby eyes from the light, from the direct light. If you open the incubator and there is light, please cover the baby eyes. Please avoid noise, especially the door noise and the internal channels of the hospital. Please don't put anything over the incubator. Please don't bend on the incubator. Please don't knock on the incubator. When you move the incubator, please make it not to stumble or make noise. Please keep the conversation away from bedside. Look at the vital signs from the monitor and keep a quiet zone for the baby. When you close the incubator windows, please do that gently. You can even play music around, soft music around the baby. Please decrease the tone of the alarms. Please be aware of any potential noises around the baby. Please mute or decrease the tone of the internal speaker of the hospital. The skin. It's very important to prevent skin breakdown because it can cause infection. So minimize the use of tape as much as you can. Always use clear dressing. Use wrap rather than tape as possible. Please use water when you remove adhesive. Don't pull the adhesives. You can use oil when you want to remove them instead of water, sterile water. You can use always gauze to wrap instead of tape. But when you circle the limb by the gauze, make sure that not to compromise circulation. Monitor the skin very closely for redness or breakdown, especially the back of the head and the neck and the back in general. Always, every day, the skin health need to be documented every shift. So you have at least 2 assessments of the skin every day. Look at the vulnerable area of the skin. Apply barriers, cotton or gauze, such as the bony prominence. Avoid using alcohol. Do not use povidone iodine, please, in babies 25, 24, 23 weeks. You can use sterile water to clean and to remove residual solutions. You need to change the diaper always, but please wrap the diapers to be away from the umbilicus. When you wipe, you need to wipe with sterile water, please, not alcohol. The bathing of the first week should be on day 4. You can use lukewarm water, a little bit warm water, and use a wipe to clean the baby. Prevent tap water exposure, please. If not available, the wipe bath, you can use a warm sterile gauze. If a breakdown, it's important to put a gel on it and then cover it to prevent friction. If the irritation occurs at the oxy monitor, please make sure that you'll be changing it. Please always monitor the areas where burn or abrasion can occur. When we use transcutaneous monitor, we should decrease the temperature and change the place every 3 to 4 hours. Okay. There is always to be hydrocolloid gel between any adhesive tools and the skin. Developmental care, I will pass this because I don't have time for this. We can discuss it later. But the most important is providing a nest, and if possible, we can provide kangaroo care in the first 72 hours. And I don't think we should do that because we need a special training on that to do that. Okay, and I think I'm done. Any question? Now we need to start the resuscitation. So we need delay cord clamping. We need the 2 trial of peripheral IV. We need to start the caffeine, and then we need the antibiotics. We need the CBC. We need also the blood gas, the chest X-ray or ultrasound, and how to move. Once your baby arrives, we need the temperature, we need the sugar, and we need the oxygen on arrival. And we need the timing. So we need to go at least 2 nurses and 2 doctors to care these babies. Questions? Questions? Any question? No questions? Okay, thank you very much.